The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey everybody, welcome to Sepsis Syndrome, where we're going to look at sepsis from a wide optic. And this is going to be an introduction to the ultimate masterclass on sepsis. As we know, sepsis guidelines change constantly. Research drives those treatment guidelines, and this initial lecture is going to be on really an overview of what's going on. And then if you take this from the webinar standpoint and want more, this is going to be a 5 or 6 module full masterclass on sepsis. So join us. Objectives. We're going to discuss the early warning signs in sepsis. We're going to look at current surviving sepsis campaign guidelines, specifically 2021. We will look at past guidelines and compare some changes. And we're going to look specifically at the Society of Critical Care Medicine and how sepsis and septic shock is defined. When we look at sepsis from the treatment paradigm, is this the sepsis response that you see in your current hospital? What type of response is warranted for this disease process? Should it look something like this? We know this is the standard level 1 trauma response, but should a sepsis response look similar? The healthcare impact on sepsis is obviously massive. 250,000 people die every year. It's actually the 3rd leading cause of death in the U.S. And when you look at just the understanding of sepsis, 55% of adults don't even know what that word means. 1.6 million cases of sepsis every year. And when you look at children, over 5 million kids die from sepsis every single year. So this is a global killer. This is something that we have to get ahead of. We have to understand. We have to continue to look at from the research side. When you look at just all age groups, and I love this graph, the suspicion of sepsis admissions and the mortality based on age and gender. When you look at this, look back here at 18 to 25 years old. And I think what's very odd to me is it seems like females have a much higher admission rate than males. And as this linear line starts climbing, the older we become, obviously you can see a linear line and the increase in mortality. But notice that once we get between, in the late 40s, early 50s, the admission rates actually flip. We're not seeing as high of admission rates in women, but it actually flips to men. And it starts climbing higher and higher until once you get greater than 85, it flips back. And now I would hypothesize the reason why once you get greater than 85 that you have a higher female admission rate is because men just don't live as long as women. And there's more women out there at that elderly age. But just notice how high of a mortality rate in comparison to age. And I think that's something that we probably already knew. I think the younger the patient, though, I think it's interesting that more women are admitted. Again, pretty low mortality rate overall. When you look at related death in patients greater than 65, and you look at a 20-year span, Obviously, this chart shows per 100,000 population. The older you are, the more apt you are to die from sepsis. Again, I don't think that's anything that we didn't already know. So when we look at the incidence per 100,000 population in just 20 to 44-year-old men and women, notice that without comorbids, until you reach about 35 years old, you start seeing a slight increase in mortality, with a much higher increase in mortality as it moves up into that 44-year-old range in men rather than women. But when you move over to this right side of this chart, notice that once you reach 35 years old, with comorbids, men have a much higher increase, and that line starts to skyrocket all the way up. So what this says is that men with comorbids has a much higher, based on that incidence per 100,000 population, of having mortality than women. If you have no comorbids, then you're much less likely to have death. And we know when we look at this past 2 years with COVID-19, even in kids with past medical history, with obesity, with any type of comorbid, they're much more likely to have problems, and mortality is higher. And that goes across men and women. But when we look specifically at mortality based on the number of admissions, and you start isolating the disease process, why did they enter the hospital? Notice the big difference. And again, when I started looking at this chart and I was building this course, it really didn't surprise me. We know that if you have a perforated bowel, probably not a good outcome. You have aspiration pneumonia, you have any pneumonia that is, a true bronchopneumonia, patients aren't going to do as well. And length of stay is much longer. So when you look at specific disease processes or certain insults, and then you look at length of stay, mortality increases. What about patients that have already been in the hospital and then they're readmitted? So readmission, and you look at the number one, the cost associated, and then you look at specifically the disease processes that cause them to be readmitted. Sepsis is actually number one. 12% of all hospital readmissions are related to sepsis. And you can see, you go all down the line of heart failure, pneumonia, all the way down to respiratory disease, COPD, and an MI. But look at the cost associated based on that readmission. It's huge. And when you look at that, $20 billion in healthcare costs. Most of those patients do not reach functional independence, and 40% of them end up moving into a long-term care facility, with another 30% dying in the hospital. When you look at overall survival after 1 year, less than 50%. So this is a real big deal, but it doesn't get the same media coverage. It doesn't get the same attention that we see with heart disease, stroke, things like that. And again, it goes back to 55% of all adult patients don't even know what the term sepsis means. Many of these patients have these complex past medical histories. They have comorbids that lead them to the hospital, right? They end up with long lengths of stay, greater than 8 days. Maybe they're event-dependent patients. Maybe they have a trach already. We see a lot of these patients we know coming in from long-term care facilities, nursing homes. They're already septic. They might have wound management issues that lead to sepsis. And obviously, then they move to multi-organ failure and death as that disease process progresses. And as we saw in the previous slides, as length of stay in the ICU increases, mortality goes up linearly, and we have poor outcomes. When we look at the big picture and we identify where does the primary insult happen, really, we have 4 core areas: our kidneys, our skin, our lungs, and our intestinal tract. And really, when you take the top 2 from that list, the respiratory tract and urinary tract, those are the 2 most common locations for suspected infection. But we have to take that a step further and look at, well, where is the patient located when this infection happens? And that's where we get into those source sites, right? Are they in the hospital already? Are they in a long-term care facility? Are they in a rehab facility? And we know that we've seen patients, we've transported patients. I've seen hundreds of patients in long-term care or rehab facilities. Nurses listening, you've seen many patients that come into the hospital that end up infected. And that leads to, again, that sepsis. And so this is a great representation where it looks at, the healthcare cost and utilization and the top 20 most expensive conditions treated in the U.S. And this was in 2017. And look at sepsis as number 1, right? We, again, focus so much attention on MIs, and MIs are number 4. So it comes back to, do we put enough emphasis on sepsis education? Do we have early access to care? Do we have the correct response when these patients come into the facility? And so let's start looking specifically at, where do these guidelines originate from? One of the areas that we have to touch on is the concept of sepsis 2 and the progression to what's called sepsis 3. And sepsis 2 and 3, the international consensus definitions for sepsis and septic shock. Sepsis 3 is the newest guidelines. And that's not to be confused with the surviving sepsis guidelines, but this is a separate, specific guideline looking at it from an international consensus overview. And one of the big differences that we saw from the progression of sepsis 2 to sepsis 3 is, notice we don't have severe sepsis any longer. And some of you may not realize that, right? I hear this severe sepsis used all the time, and it's just because it's habit. But really, they made it more simple. And so we're going off of sepsis 3 guidelines, where we have a surge response, then we have sepsis, and we have septic shock. Again, we're not going to address severe sepsis. And so when we look at the classifications, again, looking at specifically, we have an infection. Surge response is simple, right? Patients end up in the ED or calling 911. We have to be able to assess them from a surge response standpoint. And that's a patient with a heart rate greater than 90, a respiratory rate greater than 20. Notice temp greater than 38 degrees Celsius or 36 degrees Celsius or less than 36 degrees Celsius. White blood cell count greater than 12K or less than 4K. And that would be a surge response. If we progress and look at specifically what is sepsis, well, that is, hey, we have a surge response and we have a confirmed infection. And lastly, septic shock. And this is basically sepsis. So again, we have our surge response, we have a confirmed infection, but now we're starting to look at, okay, we have a hemodynamically unstable patient. Is our MAP less than 65? Do you have lactate greater than 4 after fluid administration, fluid management? Now, we're going to talk about this, and I don't want you to confuse this with what current guidelines are recommending. I'm trying to give you a complete overview, and we're going to see changes to specifically that lactate. And that's where we get into the Society of Critical Care Medicine and the international guidelines that were released in 2021. And so the definition of sepsis is, as we've always known, a life-threatening organ dysfunction caused by a dysregulated host that's causing a response to an infection. And so when you look at the criteria for sepsis, we have SIRS, we have sepsis, we have severe sepsis. Really, it's suspected. You've got to suspect it. You've got to have a response. We have to have assessment tools to evaluate. And so what we're going to touch on is a concept called QSOFA. Suspected or documented infection and an acute increase of greater than 2 QSOFA points. And they're using QSOFA, again, we're going to see some changes, as a proxy for organ dysfunction. And so as you can see, QSOFA has from 0 to 4 points. It's looking specifically at respiration. It's looking at that PaO2 FiO2 ratio, looking at MAP, looking at liver function, looking at platelet count, looking at Glasgow Coma Scale. You're looking at specifically renal function. And so when you look at SOFA guidelines, again, this is without the Q, so just SOFA guidelines, there's a lot of different tools within here that you have to look at. But some of this stuff is not readily accessible in those first few minutes of treatment. So we have to have a good way of identifying and having a high index of suspicion. And that's where you add the QSOFA side to that, and that is make it a little bit more simple. And so what they came up with was looking at, hey, do we have a systolic less than 100? Do we have a patient that has an altered mentation? And are they tachypnic? Do they have a respiratory rate greater than 22? And so when you look at just the QSOFA standpoint, if you have a score greater than 2, that suggests the patient has a higher possibility of a poor outcome. Now, this was published in JAMA in 2016. And there's some different mindset now regarding QSOFA that we'll touch on. So are we recognizing sepsis? Again, think at those first couple slides and the comparison of what we might see in the hospital versus, hey, you go into a level 1 trauma center and you bring a trauma patient in. What's the response? Should those responses be the same? The CDC put out a report in 2016 that said 72% of patients presenting with signs of sepsis actually had huge missed opportunities. An interesting 24% of infected patients had QSOFA scores of at least 2 or 3, but accounted for 70% of poor outcomes. So only 24%. So 76% of patients did not have QSOFA scores reaching that 2 or 3 like we just saw in the previous slide. And so when you look at QSOFA and you validate QSOFA, remember the Third International Consensus Conference on Definitions of Sepsis, so that's the Sepsis 3, identified QSOFA as a predictor of poor outcome in patients with known or suspected infection. Studies have shown that QSOFA is more specific but less sensitive than having 2 of the 4 SIRS criteria for early identification of infection. Again, we're looking at specifically organ dysfunction. So when we come back to, hey, is QSOFA the best way to approach assessment? We've seen a big paradigm shift where that was really the key. And we've taught this at FlightBridgeED for the last 4 or 5 years. But what we're seeing based on the new studies is it's not the best, right? We need to be looking at SIRS response specifically. So when we come back to and look at just QSOFA again, think about how many patients you could come across that have a systolic less than 100. Obviously, altered mental status is by itself, but we could also see patients that are a little bit tachypnic, greater than 22. When we look at the Surviving Sepsis campaign and the 2021 guidelines, what it's saying is that, hey, you know what? SIRS response is the new screening tool for sepsis or septic shock. And they're recommending against using QSOFA. As we move through, if you decide to take the entire course and you move through the course, you're going to see that there's a lot of areas where they feel like there is a weak recommendation, right? Very poor quality of evidence. And this is one of those that they feel is very strong at this point. Now, this could change. So I want you to keep an open mind, be very objective. Things change. Or we could see this become the dominant way we assess our patients. So if we expand on QSOFA and we add lactate to it, and I briefly touched on lactate. This is a chart that was put out by JAMA in 2016. And this is the proportion of patients based on percentage with serum lactate in the QSOFA categories. And so go here at the bottom, I have this area highlighted. And notice that when a patient has a serum lactate greater than 4 and a QSOFA of 1, mortality was right around 7%. But when you compare that to patients with QSOFAs of 3 with that lactate greater than 4, mortality increased significantly to 43%. Now, how is this looked at now? Lactate from a assessment standpoint is looked at as a weak recommendation. You listen to some of the top docs in the world. You listen to specifically Scott Weingart. I know his stance has completely changed where, hey, you know what? That initial lactate, that's pretty good. But once you get past that hour, I don't know really if there's a lot of support in evaluating it past that point. There's a lot of different factors that can drive lactate clearance. And so, is lactate the best measurement from an ongoing care standpoint? What if we modified QSOFA? What if we added a couple more elements to our assessment? Because if you go back and you think about, okay, well, man, we have a systolic less than 100, we have an altered mentation, respiratory rate greater than 22. What we were seeing was we were having a lot of false activations. And that may be why you don't see the same level of response, which is unfortunate in comparison to those level 1 trauma activations. And so what they advised is, hey, what if we added a couple more elements and we said, hey, let's put end-tidal CO2 on these patients, nasal cannula, side stream, evaluate end-tidal CO2. If it's less than 25, that could be significant. And what if we looked at lactate after that 1 hour and we said, hey, is lactate greater than 2 after the 1 hour? That's also a significant finding on top of those 3 core QSOFA guidelines. And so when we apply this, let's say we have a 52-year-old male, comes into the ED, productive cough, he's febrile, has some chills. These are his vital signs. His BP is 92/48, his heart rate's 118, he's got a MAP of 62, respiratory rate of 18, SAT of 90%, and his temp is 38.8. Does this patient have any SIRS criteria? Again, don't look at this from a QSOFA standpoint. Let's look at this from a SIRS standpoint. And if you picked out, hey, yeah, this patient has a heart rate that's greater than 90, patient definitely has a temp greater than 38 degrees Celsius. And so we could definitely say, hey, 2 SIRS criteria are met in this patient. Remember, that was significant. So if we recap that SIRS definition, remember we're looking for two of the following. That temp, is it greater than 38.3? Is it less than 36? Is that heart rate greater than 90? That's a pretty low threshold, honestly. Respiratory rate greater than 20. You can take that a step further. Hey, do we have a PaCO2 less than 32? Remember, end-tidal CO2 is always going to be lower than PaCO2. But remember, if you have a patient that is hemodynamically unstable, that end-tidal CO2 could be significantly lower than that PaCO2 because it's perfusion related. And lastly, do we have a white blood cell count greater than 12K or less than 4 with associated band formation of 10%? The question I want to ask, though, is SIRS just a specific marker of sepsis? Or could it be associated with a lot of things? And I think that is the thing we have to understand. Even though we're using it as a marker in sepsis, SIRS can happen in lots of different disease processes. See, it's seen in burn patients, it's seen in trauma patients. You can have patients that with autoimmune diseases, right? Pancreatitis. And so it's not specific to sepsis. It is sensitive. And that's where we use it as an assessment tool. And so when we look at all the aspects of SIRS, we looked at that respiratory rate, we looked at the white blood cell count, the temp, etc. Out of these different parameters from A to F, what would you hypothesize is the most important parameter as far as a indicator that your patient is getting sick or is infectious or is declining? Is it the heart rate? Is it respiratory rate? Is it simply, hey, we have a low SpO2? I think we always put a lot of emphasis on that SpO2. And as you've seen in different teachings that we've done, SpO2 and your understanding of SpO2 is only as good as your understanding of medicine from a broad angle. Do we understand the oxyhemoglobin curve? Do we understand what drives affinity for oxygen and hemoglobin? That relationship really impacts our understanding of SpO2. And so the key, guys, is when you look at machine learning and you look at conventional prediction of deterioration based on vital signs, in this specific study, they found that several machine learning methods was more accurate at predicting deterioration, and using specifically just simple assessment tools is the key. So these are the top 5 in assessing patients and how we identify decline. And notice number 1 is respiratory rate. I mean, by far, the number 1 predictor is respiratory rate. And we teach this all the time, guys. Remember, our body is always going to go into that sympathetic response, that fight or flight. The first thing that it's going to do is try to increase your minute ventilation. The only way it knows how to do that is to drive up your respiratory rate. So that's usually going to be the key. And then we see heart rate, we see other aspects of our sympathetic nervous system kick in. So don't discount a patient that is tachypnic. A tachypnic patient should always raise the red flags. When we look at different treatment assessment tools, one of the things we've taught for a long, long time is, hey, CVP, CVP, CVP. It was taught in sepsis for years. How specific is CVP at looking at fluid responsiveness, volume status? And so when we look at this parameter and we say, you know what, let's look at right atrial pressure and let's look at what is the predictive value in response to looking at, hey, is my patient going to respond to fluid? notice that CVP actually came in at 0.56. And when you look at this area under the curve, which is abbreviated AUC, notice that it really fails. It's all the way down at the very bottom, guys. And we put so much emphasis on driving resuscitation, driving volume status based on CVP or a targeted CVP. So if we take that same concept and we say, what is the predictive value of SOFA or QSOFA? This was published in JAMA in 2016. So again, this is 6 years old. We know that the guidelines now are a little different, but we want to review what we've done in the past. If we go back to our AUC chart and we say, what is good? Good is 0.8 to 0.89. Notice that really QSOFA from an outside the ICU assessment is in that good range. Nothing falls in that good range inside the ICU, whether you're looking at surge response, SOFA, QSOFA. And so what do we take from that? Again, I keep going back from QSOFA. We know that the new surviving sepsis guidelines don't advocate for that QSOFA assessment. It's all about SIRS. We just highlighted what JAMA reported in 2016. There's been 6 years of research, right? We're in 2022 now. And so when we look at SIRS specifically, SIRS was associated with higher mortality. So if you look at this chart, notice that SIRS criteria met at admission. So respiratory rate led over heart rate, white blood cell count, temp. And then when you look at the amount of SIRS criteria met, the more you have, the higher mortality you end up having. Remember, we're trying to just identify 2. Mortality was right around 3.2%. But when you get up to 4, mortality climbs to 9%. And so when you look at SIRS criteria during that hospitalization, looking at one specific study, this study had a sample size of 269,000 patients. 47% of those patients met 2 SIRS criteria. And if patients presented with SIRS on admission, they had a higher mortality rate. So what happens, though, when too many patients meet this criteria? And this goes back to what I talked about, right? The QSOFA guideline also had the same problem, and that's why we modified that. We added end-tidal CO2. We added that lactate as a surrogate to try to weed out these false activations. Essentially, it leads to that alarm fatigue. We become desensitized, right? These sepsis activations, they were happening so often and there were so many false activations that nobody took it seriously. And so when we look at that modified aspect, is there another measurement above and beyond SIRS that really helps predict? And the answer is absolutely yes. And we're seeing over and over and over the impact of end-tidal CO2. So when they looked at specifically capnography and they looked at, again, that AUC, notice end-tidal CO2 had a score of 0.99. Remember, good is greater than 0.8. So again, we have 2 SIRS criteria met. We then add end-tidal CO2. Is that end-tidal CO2 less than 25 with suspected infection? If that's the case, then likely this patient is going to be classified as sepsis. We've probably all heard about vitamin C in sepsis, and this was a big deal 4 or 5 years ago. We saw lots of articles. Could this be the cure-all? We were seeing experiments. We were seeing, news articles saying that there was a huge success. So what does the literature say? Looking at a retrospective study, again, when you look at the hierarchy of evidence, retrospective observational studies are the lowest tier, right? We need to really look at this from an RCT standpoint. They looked at 7 months of treatment compared with a 7-month prior period, 47 patients in each group, control versus treatment. Treatment administered to severe sepsis and septic shock. So this was prior to sepsis 3 because we have that severe sepsis in this overall study. And they got a 6-gram IV per day times 4 days. They got thiamine as well, and they got a steroid. What were the results? Well, notice the control group, they had a mortality of 19 compared to a mortality of 4. So 19 out of 47 patients died in the control group versus 4 out of 47. So there was definitely a decrease in mortality. But again, this was an observational study. This was reported by Merrick in the Society of Critical Care Medicine in 2017. When you look at each group, though, each group did receive broad spectrum coverage. They both received conservative fluid management. If you followed Paul Merrick, he's all about passive leg raising, giving very little volume. They both got levofed if the MAP was less than 65. They had a secondary pressor of vasopressin added. When levo doses were greater than 20, they were all put on lung protective ventilation. Right? We were looking at patients that didn't have that hyperoxia, right? Limiting FiO2. They all got DVT prophylaxis. They didn't get any GI prophylaxis, and they didn't get any internal feeding. And so when we look at vitamin C, we know it's a really amazing antioxidant. We know that it has the ability to grab onto, it's a scavenger of those O2 free radicals. And if you're not familiar with that, that is a big, big part of why we try not to raise our FiO2. 95% of the oxygen that we take in or we administer to our patients actually is utilized in our ATP production, right, oxidative phosphorylation, and in our carbonic acid buffering. But that other 5%, those are oxygen-free radicals. At 21% atmospheric concentration, 5% is a small amount. It's really not going to cause any problems. But you increase FiO2 to 100%, you've increased FiO2 by 5 times. You've also increased oxygen-free radicals by 5 times. So we know vitamin C does have that scavenger effect, and it protects that endothelial lining. When we look at this specific study, the effect of vitamin C, thiamine, hydrocortisone on ventilator, and vasopressor-free days in the ICU, did it have any effect? This was actually an RCT, and it was finished in February of 2023. Based on the results, sample size of 500 patients, really, it was not significant. They did not have a change. They had about a 2% difference between the intervention group. So there was a 2% decrease in mortality versus 24% in the placebo. So is that significant? What does the Surviving Sepsis campaign recommend? As you can see, this is a new change. It was something that was looked at more favorably in the past, but they're now saying that there's a weak, low quality of evidence. Does that mean that physicians are still going to do this? Absolutely, right? Some of them may feel like this is warranted. Some of them may feel like there needs to be more evidence out there to really make this stance. And again, this is a consensus, right? This is a recommendation. These recommendations change constantly. And so in summary, really the world of sepsis is always changing. We have to understand that right now we're looking at the 2021 guidelines. And those 2021 guidelines are also representative of a lot of aspects of the 2016 Sepsis 3 guidelines that highlighted the change of sepsis and septic shock, and we saw the removal of severe sepsis. And really the key is early identification, early treatment, using those other methods, end-tidal CO2 being one of them. Remember, surge response is probably the key, and QSOFA may not be the way of the future. If you have any questions, please let me know. We want to hear from you. And so again, my email is eric.bauer@flightbridgeed.com, and I will talk to you soon.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.